Class, please welcome Dr. Emily Padilla. She is going to be lecturing for us today on violence risk assessment, and we are so lucky to have her. So please give her your full attention as she tells us all about the assessment of violence risk.
Well, thank you, Dr. Kaler. It's really a pleasure to be here and sharing this information with you. I'm going to be talking about violence risk today. I wanted to take a moment to just introduce myself and kind of give us a little bit of an outline of where we're going today. So, as Dr. Kaler said, my name is Emily Padilla. I did my undergraduate education at Stonehill College in Massachusetts. I then hopped coast, went to Alliant International University in San Diego, where I studied clinical psychology in an SID program, Doctor of Psychology. I was there for several years where I did practicum experiences, hands-on experiences in various forensic settings, including juvenile detention centers, locked inpatient psychiatric settings. I also worked in an outpatient clinic with individuals who were in the federal system. I took a bit of a break and then I ended up going back to school and I did my APA internship. So your final training year, I did that at the Forensic Mental Health Program in St. Peter, Minnesota. So I'm hitting all the coasts here. And then I just completed, so I knew I wanted to specialize in forensic assessment. So any assessment involved with court and forensic individuals and violence risk. And I just completed a postdoctoral fellowship at the University of Massachusetts Medical School. So I'm back in Massachusetts, and I was just hired on at the University of Massachusetts Medical School. So I'll be doing forensic evaluations for the court here to include competency to stand trial, criminal responsibility, risk assessment, and we have a special credentialing process. So I'm a licensed clinical psychologist, but we also have a special credentialing process. And so I'm working through that process now to become a credentialed forensic psychologist. So thank you so much for having me here. The plan for today, I want to acknowledge that this is a borrowed PowerPoint, so I've altered it a little bit, and we're going to be going forward with that. So the plan today is to really talk about violence, kind of define some terms, really get an understanding and a foundation for what we're talking about. Then we're going to talk about kind of understanding violence, who becomes violent, what does that look like, what are some of the contextual and risk factors that we want to consider when we're thinking about violence, and then we're going to talk about assessment. So that should take us kind of a broad overview of what violence risk assessment is. And I want to acknowledge at the outset that there are various different ways that we as psychologists do violence risk assessment, and there tends to be very different camps and opinions on how we do that. So I'm going to try and offer you a more broad perspective on both sides. But I also do want to acknowledge that I have my own biases and my own preferences, and I will call them out as we go along. So let's move forward. So let's talk about violence. Let's define some of these terms before we even get into it. So violence, we all kind of hear this word, we probably have used it. But if we think about it at the root, this can be any sort of inflicted violence, so actually acting physically aggressive towards another, punching, hitting, kicking, spitting. It could be attempted. So it could be all of those actions. However, no actual bodily contact was made or the efforts were thwarted before any sort of physical bodily connection was made. Or threatened. So someone can make verbal or make verbally aggressive, threatening statements of causing harm. And it can be physical and psychological. So it's important to really understand that. Aggression really is intended to just harm someone. And so that could be psychologically or physically. And all violence is aggressive, but not all aggression is physically violent. So we want to kind of make sure we're understanding that. Secondly, we want to think about risk. So what is that? So of course, we're talking about violence risk today, but when we think about risk kind of generally, it's really that threat, and it's the uncertainty. So will this person act violent? Will they not act violent? It's really hard to say. But the risk is that maybe potentially more likely than not, they may act a certain way. So we want to understand what we're looking at there. It's also important to remember that violence can occur in many different ways and can look very different. It's very diverse. And so we're going to talk a little bit about that later on, but I just want to kind of point that out ahead of time. When we're thinking about assessment, this is really everything that I think you guys have been talking about. It's the process of getting the information in a systematic way. Sometimes, and we're going to talk about this, sometimes our assessments are a little less systematic, but now as a field, we have agreed that the better approach is to do this in a somewhat systematic way and a very intentional, purposeful way to gather information and to make decisions or to offer opinions. Because as psychologists, that's what we do. We offer opinions to the court in this context. And then the last piece is management. Again, kind of calling this out, there are different kind of camps to violence risk assessment. One camp is predictive. So how can we say who is going to be violent? And then one camp is preventative and management. Both really have a management focus, but the second really focuses and emphasizes management and prevention, and this is through mitigating risk by addressing and targeting any, we call them risk factors, that are going to increase someone's likelihood of becoming violent in the future or moving towards violence. The only last thing that I want to say that I forgot to mention when we were talking about psychological harm, this could include, I talked about them in distinct from physical injury, but this can also, psychological harm can include the threat of physical injury in itself and other like emotional or cognitive impacts that someone might be inflicting on another person. And those, when we're thinking about psychologically harm, they are impacting someone's health, their well-being, their functioning across their life. So I just want to add that. I also want to add that we also are thinking about and conceptualizing self-directed violence. Sometimes you might hear that referred to as suicide, self-injurious behavior, thinking along the lines of cutting, burning, choking, things along that line. I do want to acknowledge for this purpose, we are talking about that as distinct from violence towards others, psychological harm, physical harm. Although there are times when potentially someone who is engaging in self-harm or self-directed violence, suicidal acts, it might also include harming other people, and so we might consider that in terms of this as well. But I did want to throw out that self-directed violence, there are risk tools and assessment tools for that as well. But this is going to be more focusing on risk and violence towards others. All right. So when we're thinking about future violence, this often, when we're asked to do these risk assessments, we're really trying to set what that time frame is in the future. Is that tomorrow? Is that in the next few weeks? Is that in the next few years? How do we know what we're looking at? It's going to be something that we're looking at proactively. Now, I want to call this out at this juncture as well, that the farther out that we are looking, so if we're trying to examine or assess years from now, 1 year, 5 years, 10 years, the worse we are at predicting future violence and the less accurate our assessments become. A lot can happen over time, a lot can change over time, and this will probably make sense a little bit once we start talking about risk factors and the different types of risk factors. But it's important when we're thinking about future violence to really set what we're looking at and to acknowledge that the farther we get out time-wise, the less valid our assessment's going to be, and the less potentially accurate our assessment's going to be. So why is it important that we do this anyway? For a few reasons. One, treatment, whether it's institutional-based treatment, whether it's psychiatric hospitalization, sometimes involuntary psychiatric hospitalization, depending on what state this assessment's occurring in, um, is one reason. Because often states, when they are doing involuntary hospitalization or when they have statutes that are addressing involuntary hospitalization, often, if not always, the major criteria for that is dangerousness or risk of harm to others or self. So the state is going to have to prove that this individual is a danger to themselves or others, so potentially violent and aggressive when we're thinking about that danger to others, and therefore is in need of hospitalization. So that's one consideration. The second consideration is, of course, community safety. We have a duty to the public to make sure that people are safe and to make sure that the individuals in our hospitals and healthcare settings and work and employment are safe. And so the court or potentially the hospital or wherever the individual is, jail, prison, might request a risk assessment for that dangerous piece to make sure that this person is ready to go to the community and that they will be safe in the community and won't perpetuate harm or won't act in a violent manner. And then the last I alluded to is for criminal justice purposes. So when do we release someone on probation? Is somebody suitable for probation? Does their risk for violence increase if they're on probation? What conditions might someone need in order to be successful on probation or in the community and in order to mitigate or reduce their risk for violence? Or at this time, based on these risk factors, does that individual need detainment? The only last thing that I want to say is just a language acknowledgement. Often you'll see criminal justice, that's very standard language, but I did want to acknowledge that some of that language has shifted towards criminal legal involvement, criminal legal purposes, just because it acknowledges that the criminal justice process isn't always just for individuals, especially individuals with mental illness, individuals, people of color, etc. And so I just wanted to acknowledge that right now. All right. So another kind of foundational mark right here that is important is this risk needs responsivity model. You may have heard of this. This is a very this model is often used within the criminal legal system and within many systems when considering violence risk. This also might be used in systems that are including sexual violence risk, which is slightly different, but considered under a similar umbrella. They use this risk needs responsivity model. So it's broken up into these three different principles. The first is the risk principle. And essentially that means when we are providing services to somebody, their level of risk should match with the services that they're getting. Because we know that when we put high-risk individuals with low-risk individuals, while at the front we might think, oh, well, individuals who are low risk, that might teach good skills, provide support, and bring those individuals who are high risk down to a low risk, which would be really ideal in that kind of setting. However, we know that the opposite happens. So often if we put low risk individuals with high risk individuals, we see that those who are low risk, their risk actually tends to increase. And if we think about prison, jail, carceral settings in general, people who go in often come out with more criminal thinking, more criminal attitudes because it's a protective factor. So yeah, they might have gone in low risk, so to speak, but in trying to keep themselves safe, in talking with other individuals who are potentially more high risk, they start to learn different attitudes, or maybe there's frustrations, and we see that those criminal thinking and attitudes, behaviors start to increase. We call that the criminogenic effect. So it's really important that we match the risk to the individual. Also, from a kind of systematic perspective, or a systemic perspective, excuse me, how those services are delivered are going to look different, and that's the responsivity principle. But if someone needs a lot of services, we want to give that person a lot of services because if we give them not a lot of services, then we might be missing something. And then if they don't need that much in the way of services and we give them too much, we're also then providing more than somebody needs. So all that to say, we want our service level to match what the need is, what the risk is in that situation. Then that leads to the need principle. This is really focusing on what we call criminogenic needs. These are those risk factors. And we're going to talk about risk factors, but this is really the target of our treatment interventions and what has led to them engaging not only in violence, this model is more broad, but them engaging in criminal behavior so that we can hopefully reduce recidivism and help them have, stable, successful lives or whatever they want for their lives. So that's the needs principle. And then lastly is the responsivity principle that our services should match the needs of the person in order to, like it says, maximize efficiency. So really we should be tailoring our treatment plans and our response to somebody's risk level and their needs, their risk factors. And we should be developing treatment plans that are geared towards and responsive to them, rather than that like one size fits all model. Okay. So let's talk about violence. Let's talk about types of violence, risk factors, how people get on this pathway to violence. So there are different types of violence, and these might be different verbs for things, different verbiage for things that you already know. So we have the instrumental violence, the reactive violence, and then of course it can be a little bit of both. The instrumental violence is really your planned, purposeful, thought out violence. I want to hurt X, and so I'm going to plan my way on how I'm going to execute that plan to hurt X. Reactive violence is really your crimes of passion, right? I'm frustrated, I'm angry, so I'm reacting in the moment to whatever the situation is. Could be internal, could be external. And then you can have situations that are a combination of both. And we're going to talk more about the causes, but I wanted to call it out right now that violence, like humans, is very complex. And people act violently for a variety of different reasons. And it's important to understand that there is a mix of both the individual factors that are happening within a person, whether it's mental health concerns, whether it's personality traits, whether it's biological, medical issues that might increase someone's risk for violence. And then there's also these situational, environmental, contextual factors that might influence somebody to act violently. And I'm going to give you examples, and we're going to talk more about that in a minute. So this is a model that is really helpful for thinking about when violence happens. So really, when we think about violence, it really happens kind of in a progression. Although for some people, this might be a really fast progression. For other people, this might happen over months, days, weeks, years. But really what happens is, one, somebody has to entertain the idea of being violent. Now, if this is more reactive, then maybe that entertainment of being violent is much quicker, or maybe they're thinking about it outside of these kind of moments of quick reaction. But all the same, somebody has to identify the idea of being violent. Then somebody has to quickly or not quickly, or over a prolonged period, kind of think about the consequences of this. So, like, what are the good things that are going to come out of me being violent in this moment? What makes it worth it? If there was no positive, nobody would act violently, probably. But there's some evaluative, positive outcome of me being violent. Then on the flip side, what would be the negative? What's the not so good of me being violent? And then 4, how am I going to overcome barriers? So somebody who goes through all of those, if the negatives out negatives are less than the positive, so this is seen as something that is good, it's going to get me where I got to go, and I can overcome the barriers, that is what could lead to violence. Now I set that up because these 3 factors here, motivators, disinhibitors, disinhibition, and destabilizers, often fall within those and might lead somebody toward violence in any of those steps. So motivators, that's going to be the evaluating the positives of the acting violently. So if I act violently, I get this. Your disinhibitors, this is really evaluating the cost of acting violent. And if it's evaluated that the negative consequences are not that bad, then that might lead someone to act violently. And then the destabilizers, this is really anything that influences our mental state and our ability to make reasoned decisions, to make potentially rational decisions, and I'll have examples of that. And so if all 3 of these come together, we can have somebody who is engaging in violence. So let's talk a little bit more about motivators. As I said, these are things that increase somebody's likelihood to engage in violence because there is some sort of reward, benefit, gain to engaging in violence. We can think about a lot of different examples of somebody who engages in violence, and for them, there was benefit to it. So it could be something like a self-defense situation, right? That makes sense. There's a life protecting factor there. So that would be motivating in those moments. My life is threatened. In order to protect my life, I need to act violently to end that situation. So you have situations like that. You might also have relational situations in which one individual, for whatever reason, they learn that they want to be in power and control. And so one of the ways that they gain power and control is through violent act, whether it's physically assaulting their partner, threatening to physically assault their partner, etc. And then there's some other examples here. One, there's a lot of different examples. I had mentioned sexual violence risk assessment earlier. This one is definitely tough for people to understand, or can be, but motivator could be sexually motivated as well. And for sexual violence risk assessment, like I said, there are other risk tools and risk measurements that you can do for that. But I just wanted to point that out as well. There are many different reasons and benefits that somebody might experience from being violent, whether it's rational or irrationally based. Okay. In terms of disinhibitors, this is, as I said, when they do their cost value analysis, when they're thinking about the consequences, and the disinhibitor is what reduces the cost of doing violence. So it's not that bad if I engage in this violence. And some of the disinhibitors that we may see may be related to mental health symptoms, but often are not. Can be and can also not be. And some things that we might see. So if we have thoughts that are supportive of violence, so or negative attitudes or negative self-concepts, I'm bad, it doesn't matter, this is what I'm supposed to do in order to be successful, I need to be violent, I need to in order to make it to the top, I need to fight my way through it. So any of those thinking patterns that might support violent attitudes because, I'm reducing it because that's who I am. So the cost has been reduced. Alienation, so isolation, loneliness. What do I have to lose anyway? I'm all alone, so why does it matter? Lack of insight, so maybe they're not aware of the costs. And then I also added substance use and psychopathy. Psychopathy is one of a big risk factor. Not having empathy towards other people, not not experiencing guilt or remorse, among other traits that can be in and of itself a large disinhibitor. And then substance use. And you're going to see some of these overlap. If we look at this slide here, you'll see there is substantial overlap of these. So something can be a motivator, a disinhibitor, and destabilizer. And actually, we see that with substance use. Substance use really can be multiple, as well as sort of mental health symptoms can fall across the three, but I wanted to call that out. So let's talk a little bit about destabilizers. These are things that disturbs a person's ability to monitor and control their decision making. So it could be mental health symptoms, it could be substance use, and it could be other things. So when we think of perceptual disturbances, if someone's experiencing paranoia, hallucinations, if they have delusional thought content, this will really impact their decision-making abilities and their sense of reality potentially, as well as somebody who is experiencing cognitive impairments, maybe having seizure activity and losing time, or maybe being amnestic and having memory impairments that might be destabilizing and impact someone's ability to make reasoned decisions, and potentially could increase their risk for violence. Somebody who's impulsive or who kind of just reacts to situations or has a thought and then immediately goes and engages in that behavior, that could be quite that could affect someone's decision making, as you can imagine, because there's not really a lot of forethought that goes into it. Somebody who is quite rigid, so they're not really able to engage in flexible thinking, kind of very black and white, that potentially is going to impact and someone's ability to engage in reasoned decisions, and so on. All right. So so we have those three, some things that might contribute to someone engaging in violence. Now, this is not an exhaustive list. And once we get into the assessment and we're going to look at risk factors, we're going to see more, but some things to just think about, because context matters and someone's lived experiences matter. And as I said earlier, people engage in violence for a variety of reasons, and it could be related to a variety of different factors. So some might include things like biological, so things that are happening internally, whether developmental from birth, or such as like temperamental predispositions, and how a baby and a mother and parent, I should say, not a mother, interact with their child. That could shape somebody's experience, but it can also be kind of acquired along their developmental path. So when we think of teratogen exposure, this could be something like fetal alcohol syndrome, as said on the slide, or any substance use that the pregnant person does when they are pregnant with the child. That can impact somebody's cognitive abilities. It could impact someone's impulsivity. Again, potentially increasing their risk for violence, their decision-making abilities, things along that line, as we just talked about. Toxin ingestion, for example, lead paint, traumatic brain injury, if somebody damages parts of the brain that impact decision making and our executive functioning, so our ability to plan, our ability for attention, and our ability to make decisions, then that could increase somebody's risk for violence or contribute to someone's violence. We also have social factors that contribute. This could be learned patterns of thinking, behaving, feeling from early social environments. So as we age from childhood, we learn a lot from our parents, and then we have social groups, and then we start to learn a lot from our peers, and we start to really incorporate, all of these different scripts or norms into our cognitive scheme, like into our perceptions of how things are supposed to be. And so, based on what we've learned, potentially, there could be things that we learn along the way that might either motivate us towards violence. We learn that there's some reward in it, or potentially we learn that the cost is low. So there might be something socially that we have learned. For instance, one of the ones that I think of is someone who grows up in a very abusive household. They might learn that love is expressed through violence. I see my mom, I see my dad, I see them loving each other, and I know they love each other, but they also hit each other. So maybe I've learned that hitting somebody means love. And so that might be something that increases someone's risk for violence, or contributes to someone's risk for violence. There's also cognitive and situational factors, as I said. Just want to point out the situational factors. Again, things like early childhood experiences. If we think of ACEs, I'm not sure if you're familiar with ACEs, that's adverse childhood experiences. But it could be adverse and traumatic experiences in adulthood as well, whether it's abuse, neglect, or any sorts of trauma. That could be something that contributes to someone's trajectory or risk for violence. There could also be other factors: frustration, hopelessness, failure to receive appropriate services, interventions, etc. These are all things that might impact someone's risk for violence. And then we have more proximal, so closer to our in time, immediate situations that encourage violence or lead towards violence, and substance use being a big one. Just go back for a second. I did want to highlight that it's important to remember, as I had said earlier, that we are complex and that somebody might have one of these factors, might have different factors. That doesn't necessarily mean that that individual is going to participate in violence or they're on their way towards becoming violent. It's important to remember that not one factor causes violence, and that violence is really influenced by many factors in somebody's individual world, their environment, their social experiences, their historical experiences, their cultural experiences. There's many factors that play into somebody engaging in violent behavior and why they engage in violent behavior. That it's more complex than saying this factor leads to violence. And we would miss individuals, and we would also inappropriately identify individuals as becoming violent when they really are not going to be. So it's important to remember that it's really contextual. It depends on the situation, and it's a mix of many different factors that could lead to someone becoming violent. I wanted to talk a little bit about personality and violence, and then I'm going to talk a little bit about mental illness specifically. So personality is really, we all have one. And sometimes people learn maladaptive ways of addressing problematic situations, of engaging in problem solving and engaging with the world, or trying to resolve any potentially internal issues, or internal struggles that might be coming up for them. And that could potentially they could be diagnosed with a personality disorder. So personality disorder is really something that is pervasive, it's inflexible. So we all have shifts in our personality. We all engage in what we call maladaptive, so less productive ways of problem solving. We all do that. It's very normal. However, when that becomes the stable and pervasive way that an individual interacts with the world and how in how their inner experience and behavior is shaped, then they might meet criteria or be diagnosed with a personality disorder. It's also important to note that this is also contextually relevant. And really, when we think of something that is pathological, um, this is something that deviates from that individual's culture because we recognize that there are cultural differences in how we interact with the world and how we, problem solve and engage in these things. So this would be something that is different, pervasive, long-standing, inflexible. So it's really hard to change. And across situations and across contexts, this is when somebody might be diagnosed with a personality disorder. Personality disorders really affect the way individuals think, the way they feel, and how they interact with the world from a relational and interpersonal standpoint. And so when we think of cognitively, this is going to impact ways of perceiving themselves, perceiving others, perceiving the world, and perceiving various events that happen in their life. When we think of emotionally, so affective responses is really our emotional responses. It could either mean a larger range of emotional responses or a very small range in emotional responsivity. The emotions could be potentially very intense. They can be very labile, so kind of vacillating and fluctuating at potentially a rapid rate. And the appropriateness of the emotional response might be either larger than you might expect, so somebody who becomes very emotionally reactive to maybe more minor situations, or the opposite, and then the interpersonal functioning. For violence, when we think of personality disorders, some common ones that we might see with individuals who are engaging in violent behavior is antisocial personality disorder, psychopathy, borderline personality disorder, and narcissistic personality disorder. So I wanted to highlight psychopathy here. We had mentioned it earlier, but psychopathy is a risk factor that can be correlated with, not causal, but correlated with somebody engaging in violent behavior. So it's important if somebody is potentially meeting criteria for psychopathy and antisocial personality disorder, that we consider that in our risk assessment. All right. So mental illness and violence, this is something that is complicated and often very misunderstood. So if you ask somebody not taking a psychology class, somebody not familiar with forensic work and violence risk assessment, your average everyday person, they would likely say that somebody who is experiencing symptoms of mental illness is likely going to be violent, or they would say that mental illness causes violence, and we know that this is not the case. We know that most people who are not mentally ill and most people who are violent are not mentally ill, and most mentally ill people are not violent. Somebody who has mental illness is no more likely to be violent than than the general public. But there is this misconception. One, in part due to media coverage, language surrounding cases that involve mental illness and violence, and then also stigma. Stigma towards individuals who experience mental illness, being scary, or again, the thought that they're violent. And that's just perpetuated through society, the way we discuss mental illness or don't discuss mental illness, the way it's portrayed in the media. And so we have this misconception that there's this really strong link between mental illness and violence. What I do want to say is that there are symptoms of mental illness that can increase someone's risk for violence. So that's different than saying that people with mental illness in and of itself, that's a risk to become violent. But there are certain symptoms that might increase someone's risk to being violent. And I have here those threat control override systems. So if we think of somebody who might be experiencing hallucinations, they're hearing voices that other people don't hear, and those voices are commanding in nature. And not only are they commanding in nature, but the voices are telling them to be violent. Well, that in of itself is going to increase someone's risk to violence. They might have delusions, so fixed false beliefs that are not able to be, they're rigid, they're not able to be flexible with counter evidence or other evidence that that belief is untrue. So delusions of violence, and specifically delusions of justified violence. So I am the savior. I am here to, save the world, but only a select group of individuals. And so everyone else who does not fit that, my duty as the savior is to eradicate that group. That is going to increase someone's risk for violence, and for obvious reasons. Active symptoms of psychosis. So again, those delusions, potentially, or hallucinations, and mania. So if somebody is in a manic episode, they're high on top of the world, nothing can stop them. If we think about our motivators, disinhibitors, and destabilizers, someone in a manic episode might be impulsive. They might think that nothing can hurt them, so why does it matter? And so you could see how that can increase someone's risk for engaging in violence behavior when they're having a manic episode. And so it's important to think about those two specifically, psychosis and mania, in the context of motivators, destabilizers, and disinhibitors, because we could see how that could potentially increase someone's risk for violence. And again, context matters. The last thing I want to say is comorbid substance use. So somebody who has mental illness and substance use at the same time. Now, if we look at this slide here, we'll see kind of on one side, predicted likelihood of violence at time 2. And then on this side, we have kind of different groups. So individuals with no SMI is severe mental illness. So no SMI or no substance use. We see these rates are pretty low, and we see the 2 bars are somebody who's experienced adverse events versus individuals who have experienced no adverse events. So no serious mental illness, no substance use, it's relatively low. And then we have serious mental illness. So this is going to be your psychotic disorder, psychosis, bipolar disorder, major depressive disorder. It's higher. So we see a little bit of an increase here, especially for those who've experienced adverse experiences. Substance use, it's still a little bit higher. But then when we get to other mental illness, so potentially anxiety disorders, trauma-related disorders, eating disorders, etc., plus substance use, we see that this increases pretty substantially, especially for the adverse events group. And then when we have severe mental illness and substance use, again, we see these are pretty high. So substance use plus mental health symptoms, there's potentially increased risk there. Again, you probably heard me say this for the 5th time, context matters. When we're thinking about doing risk assessments, it really can be, it really is important of the context, where the population is, where the individual is that we're doing the risk assessment, potentially what mental health symptoms they're experiencing, not potentially what mental health symptoms they're experiencing. And that's going to impact what comparison group, if we're doing statistical based predictions that we're looking at. And so it's important to really consider these different factors. The presence of mental illness does not predict violence, let's say in a prison setting, over other factors. So somebody who is experiencing mental health symptoms in prison, that isn't going to be as big of a risk factor than potentially somebody who is experiencing mental health symptoms in the community. And in fact, somebody who's experiencing mental health symptoms in prison, that actually might be I don't want to say protective factor, but that might reduce somebody's risk for engaging in violence. Potentially they're having services, they're in potentially a different unit, segregated. There might be different reasons why that rate is reduced. But it's just important to consider the context where the individual is and how that's impacting their functioning overall. Again, highlighting that even in the community, the presence of mental illness alone only minimally increases the risk for violence. It's really those symptoms that could potentially, that are increasing someone's risk for violence. If someone's having symptoms, paranoia is another big one I didn't mention. Those specific symptoms we're looking at that could be tied to increased violence. Okay. So let's talk about risk assessment. So first, when we're thinking about risk assessment, we have to think about risk factors. There's really two different risk factors that we look at. The first is static or fixed or stable factors. So these are factors that happened or that are identifying factors or are things that cannot change. So historical factors, that could be, criminal history, history of violence in the past. This could be problems at work, relational issues, domestic violence, trauma. These are all things that happened to us in the past. And then it could also be factors related to us as identifiers, such as current age of first offense, gender, things along that line. Then we have dynamic factors. These are factors that fluctuate. They can change over time. They're potentially variable. These factors could include things like symptoms of mental illness, so potentially taking medication, and those symptoms, severity, intensity, or presence at all might change. Could be our attitudes, our thoughts, our beliefs, a whole bunch of things that could be targeted in treatment and potentially change to reduce somebody's risk to violence. Common risk factors, I have mentioned a few. So when we think about risk assessment, these factors are some of the factors that are common across the various types of risk assessment that somebody would be looking at. That's going to be criminal history, antisocial personality patterns. We talked about psychopathy and antisocial personality disorder. Thinking that supports engaging in violence or criminal behavior, peers or associates that support engaging in violence, potentially gang-related associates or associates who promote violence, supremacy groups, things along that line. And then we have relational issues, education, work issues, substance use, and then issues with leisure and recreation. When we're thinking about the various ways in which we can approach this, there is a spectrum of how individuals have engaged in risk assessment. And really, this falls into three different approaches, some of which are still used today, and some of which we actively recommend against. So historically, traditionally, individuals started with just using our clinical judgment. So I am going to sit down with this individual, I'm going to review the records, and just based off my experience and my judgment alone, I'm going to make a determination on how risky I think this individual is. There's no structure to it. There's no guide to it. Just based on my judgment and my experience alone, I'm going to make a determination. I'm going to tell you right now, we're not good at this. I think we like to think that we are good at this. We're not good at this. And it makes sense why we're not good at it. We talked about stigma. We talked about media influences. We're also empathetic humans typically who are in the field of psychology, or maybe not, but these are all different factors that bias us, and we might see different psychologists or different risk assessors who are doing this unstructured clinical judgment come up with wildly different outcomes. Then we have the all structured approach, which often is called our actuarial approach. So this is very statistical based. The focus is on predicting who will or who won't be violent. And these factors that are on these types of measures are usually factors that are static, that are historical, things like age at first violent offense, number of violence offenses, um, number of different diversity of victims, things along that line, and it's going to produce a numerical outcome. So you put it into these standard structured tools such as the VRAG, that's the Violence Risk Appraisal Guide, and then it does its computation and you get some statistical output that predicts whether how likely this person is going to be violent or not based on a comparison group. So if you get a 2 on this measure, then you are considered high risk. And if you get a -2 on this measure, then you're considered low risk, things along that line. And then we have this third group and this third approach, which is what we call SPJ, structured professional judgment. So it's kind of the mix between, it's kind of in the middle of that continuum between that unstructured judgment and the all structured judgment. This is really that mix. So really it looks at a combination of those static factors, so those things that are unchangeable, historical factors, as well as dynamic factors. So things that can change, that are variable, that do fluctuate. And it really looks at both of those. And it switches from a predictive model to a prevention model. And it really looks at the context and the things that we can address and influence to move someone away from violence and those factors that might move someone towards violence. Now, I told you I would call out my bias. This is one of them. The actuarial versus the FPJ, there are two very strong camps on either side. I tend to lean SPJ and more of that preventative mitigation management camp. So I just want to call that out at the outset. But they both have very similar predictive validity in terms of outcomes. All right. So in terms of, I just want to say a little bit more of this. This, like I said, really bridges that gap between those two kind of ends of the spectrum. And it is much more prescribed. So it's really a guide. So we're using our clinical judgment, but in a very systematic, guided way. So I'm going to take this person as they are, review the records, interview, and based on these identified risk factors, I'm going to really see where this person and what kind of risk factors and life experiences this person has had and what they're currently experiencing that might influence them towards violence. There are tools, one being what we call the HCR20, that really structure and help the professional kind of weigh and combine these different factors on when they're doing their risk assessment. And the primary purpose, as I said, is really that prevention and mitigation. This allows for kind of a systematic link between risk factors. So I'm identifying these risk factors, and then because I identified them, I can now map that on and say without treatment, without medication compliance, without monitored use of, without sobriety, then this person would be at a greater risk for violence. And so we can really kind of map the two together, which is helpful. So this is a tricky question about which is best. Again, as I said, there are two different sides. There's groups that will argue either way. I think to some extent it depends on what your goal is. And so we know we're not going to do unstructured clinical judgment, but there are reasons why someone might do an actuarial and a statistical based risk assessment versus an SPJ. So somebody who's doing an actuarial assessment, this is a really standardized assessment. It's based on statistics and constructs that have been validated over time. And it's very predictive of recidivism, so someone engaging in violence again. And it can be used to help categorize. Remember when I said R&R and high risk, low risk? This is one of those tools that can help categorize where somebody falls and what risk level they are and how can we address those needs and be responsive to them. Using these measures might be one way. Okay, if someone is above a 1 on this measure, then they would be considered high risk. And if they're below -1, then potentially they're low risk. So that could be one reason for that. The problem at times is for some of the measures, items might not have that same rehabilitative value. So we can't change when somebody first committed their offense because remember, these are static factors. Somebody can't change they just can't change their criminal history. It happened. So there might not be, it might be helpful for identifying the risk, but maybe not so helpful for identifying criminogenic needs and doing the next part of the R&R model. In terms of SPJ, this can be really helpful when we're trying to think about reducing someone's risk for violence and when we're trying to make decisions whether to release or not, how the treatment plan should happen, what kind of treatment they need, what are those criminogenic risk factors, those criminogenic needs that need to be addressed. SPJs are really good, is it one really good tool to help with that? Because remember, it does address a mix of both static and dynamic factors that could potentially increase someone's risk for violence. And so we can use that to help mitigate. All right. Things that I want to kind of end on and things to think about is that the rate for violence is, the base rate for violence is actually pretty low. I know we see it a lot in the media and it gets a lot of attention when these atrocities happen, but the base rates are pretty low. And so that's something that we need to take into consideration when we're making these, doing these evaluations. And the error rates are high, potentially. So you're either right or you're wrong. And the court, of course, wants us to make a decision. Will this person engage in violence again? And it's really not that easy. And we aren't able to make that decision. We're not fortune tellers as much as sometimes I would like to know what's going to happen in the future. I do not have that ability. And so we're not able to make those really concrete decisions. And if we get it wrong, there's really huge consequences. So let's say we have an individual that we're assessing and we say, yep, I've looked at their scores, I've done the assessment, and that person's going to reoffend, and they don't. Well, now that person is potentially detained, whether in jail, a carceral setting, or a psychiatric hospital if they're experiencing mental health symptoms, when really they weren't going to engage in violence in the future. The opposite, so let's say we're like, nope, this person, good to go, not going to engage in violence, we're not concerned. And then that individual is released. They don't get treatment potentially. There's no supervision via probation or other means. And then that person does act violently. Potentially that could lead to loss of life, community harm, psychological harm, individual harm, and we have another problem. So this is really important to consider when we're doing our risk assessments and when we're deciding how we want to approach our risk assessments, that while the court or whoever is asking for this risk assessment, the detention center, the psychiatric facility wants these definitive answers, sometimes we need to take a step back and really consider all the factors. And this is, again, my bias why I like SPJs, is because then we can come up with a plan and think about situations that might increase someone's violence or decrease someone's violence. So something to think about. Um, the utilities of the tools. So this is the other thing. There's tons of tools for both sides that you can use. They are as good as we are in using them. So they are meant to be used as guides and in certain fashions with when we're considering all of the different risk factors and how we consider the risk factors. So really, they're going to be as effective as we are in being consistent with them, in being consistent with how we make our decisions, and how the group, let's say we're doing an actuarial, how representative or generalizable that the group that we're comparing this individual to. So if we have a culturally diverse individual and we're comparing them to kind of the Eurocentric population, that might not speak to their actual level of risk or vice versa. So it's important that when we're doing these, when we're making decisions, we're being thoughtful about them. We're thinking about the context in which the violence or the risk factors occur, and we're considering how those risk factors interact with each other and how those might increase someone's risk for violence. So kind of wrapping up this kind of overview of risk assessment, the things to take away and the things to think about. We don't do clinical judgment.